I am here to introduce Jazmine Valencia, who is one of our neonatal nurse practitioners. She's been with us since coming from the actually adult side, and has been such an addition to our group of practitioners. She loves teaching. She's actually always getting compliments from the nurses for always being willing to just stop and talk to them. So that's Jazmine. And then Kathy Romero, who needs no introduction. She's been doing neonatology longer than any of the rest of us. And I'm really proud and happy to have both of them talking to you today.
Well, good morning, everybody. I'm hoping you can see my screen. Is it there? Jazmine, give me a thumbs up if it's there. Okay. Well, good morning. Actually, I'm on the wrong side of my presentation because I was going through it. So, you know, in addition to all the other crazy things that we've had to deal with this last couple of years, we have to go on in certain areas, and one of them is there has to be a new edition of the NRP, so the neonatal resuscitation. So the presentation itself may not be too long. We're going to do it in two parts. So I'm going to go ahead and cover the actual testing part of things when we all go in and get our cards. And then Jazmine's actually going to go over the actual practice changes that are going to happen at the bedside. So at the end, we'll go ahead and answer all of your questions about any of these things. So let's go ahead and get started. So I don't have any disclosures. I don't get to make any money off of the AAP, which is kind of sad because, you know, that'd be nice. We're going to go ahead and talk about the changes in the levels of testing that they're doing now. There's going to be differences between the essential versus the advanced testing. And then the way we actually test people out in the lab portion of things, there's this sequential practice and evaluation versus testing out. And then I'm going to talk a little bit about the changes on the online testing itself, because of course it's getting more and more confusing. They changed a lot of things. So the curriculum has changed. And if you have been doing NRP for a really long time, you'll remember about 3 editions ago, we used to do this thing where certain people took lessons 1 through 4, and then the rest of us took the rest of the lessons out through whatever they had at the time. I think it was 9. It's now 11 lessons. And then they decided to go ahead and get rid of that type of testing and test everybody out on everything. Well, now after some thought and probably a lot of research, the AAP decided to go back to testing the first 4 lessons or testing the whole book. And so they decided to go ahead and call it either NRP Essentials or NRP Advanced. So there are now 2 course options when you go ahead and sign up online. It's up to the healthcare organizations to decide which one they want everybody to take. But here's the thing about that could be a little bit difficult. I'm having a really hard time trying to figure out who would just take the essentials. So in a hospital that has like a level 3 NICU team available at all times to go ahead and respond to neonatal code situations, essentials would be appropriate for like the newborn nursery in some cases. The essentials might be appropriate for the L&D staff if they can go ahead and call somebody in if the baby is needing more than just essential resuscitation. But when we talk about the community-based hospitals, in those areas, usually the nurses and the doctors and the respiratory therapists are the NICU team at that point in time. And it's probably better to go ahead and have everybody test through the advanced modules, just so that they're all prepared for any type of thing that might come up. So what is the difference between the 2? Well, the essentials are basically, they're the ones that come in, they assess for risk factors, they set up the bed with all of the equipment that is needed, make sure that it's tested and working well. They perform all the initial steps of resuscitation, the drying, the stimulating, the positioning of the baby. They should be able to provide effective PPD, which is probably the #1 skill in NRP that is it's the most important skill actually. And they're the ones that can recognize that there's a need for more advanced resuscitation and can call for help. At that time, the advanced providers, of course, they know how to do all of the essential steps, but they're the ones that can come in, they can intubate the baby, place an LMA, help perform chest compressions, place lines, calculate and give medications. And then they're also the ones that are a little bit more prepared to resuscitate and stabilize preterm babies. So when you look at these lists, what you see that there's a couple of things on the advanced side that are really, really important for everybody to know how to do. How to perform good coordinated chest compressions to breaths is one of those things that's really a vital component of good resuscitation. And then how to calculate and give the meds. In a lot of places, it's the nurses who are going to calculate. Most of the time, we're just given a dosage and we have the weight, or we figure out the weight, and the nurses are the ones who actually calculate that out and actually give the meds after the lines have been placed. So you can see where it can be a little bit confusing as to what people need to do. So if you're in doubt, I would go ahead and recommend that you would just require everybody within your institution who takes NRP to take the advanced course at that time. So simulation format. So after you go ahead and get everybody tested out online, then you have to go ahead and decide how are you going to go ahead and simulate a resuscitation for them. And again, the AAP has decided on 2 separate types of formats. The first one is one we're really familiar with. This is a sequential practice and evaluation. This is pretty much what we do now, where we bring people in and we put them either through stations, or we cover every part of NRP in a skills-based environment. So we bring them in, we teach them how to do the bag mask ventilation, go through things like how do you place lines, do chest compressions, do those type of things. And this type of testing is best for people who who are brand new to NRP, or who don't get to use those skills a lot. And actually probably does include sometimes the NICU staff. We don't code kids like we used to. We're really good at our jobs now. Years ago, when I was a brand new nurse in the NICU and neonatology was still pretty new, we coded a lot of kids. We just didn't have as good of the equipment. We didn't have as good of a knowledge base as we do now. And so luckily, what that means is that our patients do really, really good in the NICU. They tend to be very stable. The downside, of course, is now we don't get as much practice as, to go ahead and code our kids, which is a great thing. But that means that when we go in to test people, we probably should still put them through sequential practice and evaluation. The pros to this, of course, it builds on skills on each session until all skills are fully integrated into a final scenario. It allows the instructors to identify areas where people might need practice and correct them in a timely manner. It's a very active learning environment and usually fairly relaxed in a lot of ways. It helps people put to practice things that they probably have only been reading about. And it's a lot less stressful than testing out. The cons it does take more time. This is the type of situation where we would do it for over a 4-hour period. So everybody could practice and kind of get comfortable before we finally do the final scenarios. And for advanced practitioners, they might have to go ahead and participate in these classes if there is a mixed group of people with different skill levels and experience. So you could have a situation where somebody who would normally be able to just quote unquote test out would have to practice or would have to go ahead and take part in this. Now, another pro about sequential practice and evaluation and in this situation is that if you do have that nice mixed class of people with different and varying experiences, it really does help with team building and problem solving in a lot of situations. So there's a lot of benefit to the sequential practice and evaluation. Comprehensive testing, skills testing, is called testing out. And this is something that we would do like with our NNPs and with our neonatologists and with very experienced labor and delivery nurses. They do a lot of resuscitation every day. They do the initial steps all of the time. It should be done with more than one provider, even though it's not always unavoidable to do it with one. It's better to try and do even the testing out with a team so that, again, everybody can get the feel for how it is to practice in a real environment where people have to be communicating and they have to go ahead and manage the situation together. It does include a scenario and a debriefing. You can do 1 or 2 scenarios depending on what your skill level is. For people who do complex deliveries, the skills testing should be, or the scenario should be pretty complex, just to go ahead and help them maintain those skills of the baby with the undiagnosed diaphragmatic hernia, maybe with placental abruption, anything like that, high drops, those type of things. You want to kind of go ahead and make the scenario a little bit more complex to help with critical thinking. The pros, of course, is it's quick. This format, usually you come in, you go ahead and do an equipment, have them do an equipment check, and you can do your scenario right then and there. And then you would go ahead and follow that up by with the debriefing. That is really important to continue with the whole debriefing part. The cons is that those who don't do well will have to be sent back to sequential testing. So it can delay them getting their card. And it can be really stressful. This is kind of like the high stakes type of testing that we hear about a lot, that we perform in a lot of situations. So that's one of the things that you really have to think about when you approach which testing you're going to put who through. Some important things. So the new edition is the 8th edition. The changes go live January 1st, 2020 across the board. That's when they say everybody should be up to date on the new changes. Education department should have that information about the changes out to all providers by that date. And Jazmine, of course, will go over exactly what the changes are in the actual bedside care at that point in time. Instructors and providers should follow their regular renewal schedule though. So if you happen to update to the 7th edition this year, you don't have to rush to take the 8th edition. You can wait for your 2-year renewal period, but you do have to go ahead and put the 8th edition practices into practice on January 1st. So that's kind of one of those things that's really, really important. So what are some of the changes as far as the online testing? So this is where things kind of start getting a little dicey. So, the American Academy of Pediatrics, of course, are the driving force behind NRP. And for a long time, that the online testing was being supported through HealthStream. This last time, they decided to switch online providers for the actual class, and they're called RQI. So that's one of the first things that has changed. So you no longer have to take the test through HealthStream. Now you have to take it through RQI. The rollout is supposed to be complete, and it's been kind of rocky over the last few months. They started their rollout in June, and it's just kind of been a little hit and miss. If you have a learning platform, we have Learning Central at UNM. You can go ahead. RQI is supported through a learning platform, so that should work out fine. It is a little bit more complicated if your facility does not have a learning platform because of the way RQI is set up. It used to be on HealthStream, we used to be able to, I could send one of the fellows to take the test. They could sign on to HealthStream, and then the admins would come in with their P cards, their purchase cards, and they would pay for it. RQI is not set up that way. They won't take a credit card from anybody who's not actually taking the test. So their solution for that is that they want us to buy bulk testing, and then we have to email them, and then they email us back with a code for the person, and then we have to pay for it. And so if you're not using a learning platform, it can get really, really complicated. And the other thing too is that you have to actually talk to them about the tests, the bulk testing that you're going to buy prior to starting that whole process of emailing them. So my recommendation is if you have not yet talked to RQI about how you're going to go ahead and assign your online testing, contact them right away. And I put the numbers up on this slide. And they're really good about responding also to their emails. talk to them now, because you don't want to be trying to figure this out on the first, because it's just going to get really, really complicated. The other thing too that would be really important, if you know that you have 15 to 20 people who are going to be renewing in 2022, try to get those licenses bought before the first of the year, because they're going to bump up the price by about $10 for every license. So that's something that's going to be really important to think about, especially from a fiscal point of view. Okay, does anybody have any questions? I guess we'll answer them at the end. But I think I like my little memes there. I think they're kind of funny. And then here are the resources. If you want to know more about what the changes were and why they made the changes, that very first reference from that was retrieved from that website is actually a really good reference to start with. And you can actually keep, digging through all of that information and find out why they made the changes that they made at that point in time. So I'm going to go ahead and turn this over to Jazmine, and she's going to actually talk about the important part, which is the actual practice changes and why those changes happened. And please ask us a lot of questions. And let me get out of here real quick. And I think I'm done. How do I stop my share? I forget. All right. All right, Jazmine, you're on.
Thank you.
We can see you.
Okay. Let me go ahead and share my screen here. All right, can everybody see my slides? Hopefully. Okay. All right, Kathy, are you still there?
Yes.
Okay, can you see the notes that I have?
can.
Okay, so let me get rid of those then. All right, is that better?
Yes.
Okay. All right, so thank you everyone for being here. It's exciting that we're doing the Amazing Newborns Conference again, because I know last year we didn't have it because of the pandemic. So thank you for being so patient with some technical issues, and I'm glad you're here. So this is about the NRP updates, and honestly, there are not a lot of updates, which is a good thing, because it means that we're doing things that are correct for the babies. There is a stronger and higher level of evidence supporting what we are doing in NRP. And I love teaching NRP, so I'm really happy to be here teaching you guys. So I have no disclosures, just want to point that out. And you'll have to excuse me, I have some really bad allergies today, so you might see me kind of sniffling and blowing my nose sometimes. I wanted to first go over the history of resuscitation a little bit, just because there's some really interesting things that happened to lead to where we're at today. The first one, basically, I wanted to talk about newborn resuscitation and the fact that resuscitation in general with adults, peds, newborns was pretty horrifying many years ago. And we're going to talk about some examples of that. We've had to learn a lot through trial and error to get where we are today. Artificial respiration has been the mainstay of neonatal resuscitation for about the past 40 years. And with formal teaching programs being around for about the last 20 years, so that's not very long. There's been international consensus with collaboration between people from different countries for about the past 10 years. When you think about it, it's just not a long time. Neonatology is a pretty young science. Even in ancient times, death of newborns from respiratory failure was recognized. A Chinese emperor and philosopher named Wang Ti noted that premature infants were more likely to die from respiratory failure. Keeper's Papyrus from Egypt also recognized a higher mortality in premature newborns. Resuscitation of newborns was described in the Old Testament in 1472. there was a book about childhood diseases that described mouth-to-mouth resuscitation of the newborn. And in the mid-1700s, divine intervention was still thought to be the cause of many of the successful resuscitations that happened. There was a growing interest in the revival of people with mouth-to-mouth resuscitation starting in the mid to late 1700s that led to the foundation of resuscitation societies and funding of these societies as well. Before this, it was generally accepted that once breath ceases, life ends. Hippocrates described a life-giving component in air, and I bet you guys can guess what that is. Further supporting this, Robert Boyle found that if you put animals in a vacuum chamber, they would die. So we're lacking this element, right? An English chemist named Joseph Priestley discovered dephlogisticated air in 1774 when he noted experiments that mice stayed alive longer and candle flames glowed brighter with it. Lavoisier later termed the gas oxygen, and along with Laplace, showed that respiration is an oxidative process by which carbon dioxide and water formed byproducts. They showed that lungs take in oxygen and expel carbon dioxide. There are accounts of Chaussier giving oxygen to compromised newborns as early as 1780. So that was a long time ago. In 1752, a Scottish obstetrician named William Schmilly recommended that the head, the temples, and the chest of lifeless newborns be bathed in spirits, garlic, and onion, and mustard, and first suggested the use of a type of endotracheal tube for artificial respiration. The first ET tubes were actually made of metal, so gold, silver, and reed. It was understood that if you needed to help the infant breathe, help with respiratory failure. In the mid to late 1700s, mouth-to-mouth resuscitation of stillborn infants was being highly recommended by this point. And some considered it a vulgar attempt to save a stillborn infant. The bellow used for inflating the lungs was invented by another Scottish OB named William Hunter. So they actually used a bellow to help inflate the lungs. This method remained popular for the next 50 years, along with mouth-to-mouth and mouth-to-EP tube resuscitation of babies. It fell out of favor after a lecture in 1827 by Leroy de Etulles that described an association between these types of resuscitation and pneumothoraces. So after that point, it remained unpopular for the next 100 years. So we kind of took some steps back there. But as we know, even in the delivery room, there are pneumothoraces. And this is something that happens with babies, unfortunately. So as we're progressing, in the late 1800s to early 1900s, there were several types of positive pressure ventilation devices and negative pressure ventilation devices created for infants. Continuous positive airway pressure, or CPAP, that we use today was described in 1914. And then from 1850 to 1950, during that time span, some methods that were used to revive newborns included swinging the infant upside down, also known as the Schultz method, and raising and lowering the infant's arms while someone else compressed the chest, known as the Sylvester method, and tickling the chest, nose, and throat. There was a lot of different things described as to what we would try to do to revive newborns. There were even pressure chambers that were used for asphyxiated newborns in the 1950s and 60s. As late as the 1960s, other shocking examples of how to resuscitate a newborn include tongue pulling, immersions in cold or warm water, or both, to help the newborn basically be stimulated. Rubbing, slapping, pinching, and oxygen administration to the stomach were used in an attempt to save asphyxiated newborns. A grading system of how infants were responding to resuscitation was created by Virginia Apgar. As Dawn described in her presentation about HIE, we still use the Apgar scores today. This helped promote a new focus on newborns in the delivery room. In the 1970s, the American Heart Association and the American Academy of Pediatrics realized that there was a need to improve care of newborns at delivery and shortly after. The National Institute of Health funded different projects to provide education to community hospitals and the care of newborns, including one of the precursors to NRP, which was the neonatal education program. So the neonatal resuscitation program was created in 1987. And I'm going to date myself here. I was born in 1987. And my mom likes to tell a story about how I wasn't breathing when I was born. So they hung me up by my feet and slapped my butt and I started crying. So it was successful and I'm here today. It was formalized in 2000 with the formation of the International Liaison Committee of Resuscitation. This program has been taught to millions of neonatal healthcare providers worldwide and is the mainstay of neonatal care in the delivery room and shortly after birth. ILCOR reviews scientific literature specific to the resuscitation of newborns every 5 years to see if there is any new evidence that supports any major changes in the guidelines. So as I said, there are no major changes, which is a good thing because we're doing what we're supposed to do. There are some minor changes that are more practical as to what we actually do in the delivery room. All right, so we'll go through the changes. Okay, the 4 pre-birth questions. I'm sure you all are very familiar with this. These kind of guide us to what kind of resuscitation we're going to need. Gestational age. We know that if we have a preterm infant or a preterm infant, that we might need to be prepared for more resuscitation than a term infant. Amniotic fluid color. We know that if a baby has, blood in their amniotic fluid or meconium, that we need to be prepared to resuscitate this baby, and we might want to have more people in the room. Risk factors, diabetes, pre-E with severe features, moms on NAG, shoulder dystocia. Those are all risk factors that kind of help us prepare mentally for what we might expect. And then in the 7th edition, we would ask how many babies as part of the 4 pre-birth questions. This has been removed from NRP and replaced with what's the cord management plan? Having a cord management plan helps us to have better communication with our OBs. Sometimes this can be a gray area and can be a point of contention because the baby has exited the mother's body, is still attached to the placenta. So both the OB team and NICU team kind of feel responsible for this baby at that moment. So just discussing, hey, if the baby is vigorous at birth, please delay cord clamping for 30 seconds to 1 minute. If the baby is not breathing within that first 20 to 30 seconds of life with stimulation, please hand the baby to the NICU. Just having a very clear plan is really important. One of the things I wanted to mention during this, though, is a cord management plan. When you have any kind of cord accident or anything wrong with the cord, so if you have a mom with an abruption, then you want to just clamp that cord and get the baby right away because you don't want that baby's blood volume to leave through the cord. So that's something where you would have immediate cord clamping. And so some of the benefits of delayed cord clamping for 30 seconds to 1 minute include that preterm babies have less of a risk of intraventricular hemorrhages and also necrotizing enterocolitis. And babies tend to need less blood transfusions if we're able to delay cord clamping. So this is something that's kind of come to fruition within the last 6 or 7 years. And it's been something that has been really good. So another change is the initial steps. They basically reflect better what we do as providers. So before, in the 7th edition, it was warm, maintain a normal temperature, position the airway, and clear secretions if needed, and then dry and stimulate. So those, it seems kind of out of order. So they better ordered these in the new edition of NRP. You warm, dry, stimulate, position airway, and suction if needed. All right, the EKG monitor. This came to be in the last edition of NRP in the 7th edition, where we were putting EKG monitors on babies. And I can say this has been a real blessing. Sometimes the pulse ox doesn't pick up, especially if you have a baby that's severely compromised because they don't have a lot of blood flow to the extremities. So having an EKG monitor has been really great. We would put it in on the 7th edition, we would put it on the baby before we started chest compressions to be able to get a better sense of what's happening with the baby's heart rate. This does not replace listening to the heart rate, but one of the things about that is it's kind of subjective, especially if there's a lot going on in the room, everybody's stressed out, and you know you're counting out the heart rate when you are doing the resuscitation. But the EKG monitor is just another tool in our pocket. And now it's recommended earlier in the algorithm than the previous edition. So you'll see on this algorithm here that you have your PPV pulse oximeter and consider a cardiac monitor. So that's something that you're going to do when you're putting the pulse ox on. So you just think about putting the monitoring devices on. You've got your EKG leads and you've got your pulse ox. And I think a lot of us were actually putting the EKG leads on earlier in the algorithm anyways, just because it gives us more information. So the dosing of epinephrine has been simplified. I won't say it's been changed because there's a lot more research needed about this. And NRP actually says we could still do the 0.01 to 0.03 milligrams per kilo, but they're suggesting an initial IV or IV dose of IV or IO dose of 0.02 milligrams per kilo. It's much easier to think of that and to remember that than have a range of doses. And a lot of the times we'll actually use the milliliters. So we'll say 0.2 milliliters per kilogram. And that's keeping in mind that we're using 1 to 10,000 epi. If you have a different concentration, you're going to have to figure out how much epi you need. But the suggested initial ET tube dose is 0.1 milligrams per kilo or 1 milliliter per kilogram. Before it was 0.05 to 0.1 milligrams per kilo. And I feel like this makes things, it makes more sense because if you're giving a dose through the ET tube, as soon as you establish IV access, whether it be a PIV or a UVC, you're supposed to go ahead and give your dose right away because they don't know, I guess, basically lung absorption of the epinephrine is variable. And so it makes sense to give the bigger dose, which would be 0.1 milligrams per kilo or 1 milliliter per kilogram. It just is much easier to remember, and that's why part of the reason why they changed it. And then one of the other changes is the flush after the epi. Your normal saline flush volume increased to 3 milliliters for all gestations and weights. And this is because there was evidence from an animal study that showed that using 1 milliliter of flush may actually leave a significant amount of epinephrine in the umbilical vein. So this changed quite a bit. We're just using 3 milliliters for all gestations to make sure that that epinephrine makes it into circulation. Okay, cessation of resuscitation. In the 7th edition, if there was a confirmed absence of heart rate after 10 minutes of resuscitation, it was reasonable to stop resuscitation efforts. This all depends on the context of what's going on with the baby. A recent systematic review showed that cessation at 10 minutes may preclude survival of some newborn infants who would have survived without significant disabilities. So they've actually made the cutoff 20 minutes. And I think if you've been in the delivery room and you've been through these resuscitation situations, by the time you intubate, you go through Mr. Sopa, you intubate, you give epi, sometimes several doses of epi, you're doing chest compressions, you're giving boluses. Honestly, it's been close to 20 minutes by that time. The delivery room, I like to describe it as a time warp because a lot of the times by the time you've gone through all of these situations and you've corrected everything and done everything that you can, it's been 20 to 25 minutes. So it seems reasonable, and especially if you have babies that may have made it without significant mortalities and morbidities, it makes sense that you would wait a little longer to stop resuscitation. Those are the main changes. For my sources, there's a couple of really interesting articles that I got some of the information about what they used to do for babies. And I think it's just so cool that we've come such a long way in resuscitating these babies. And so they're there, so you guys can look up those articles if you want. And at this point, I'm going to join Kathy and we'll do a questions and discussion section.
Does anybody have any questions about any of those changes or any of that stuff about having to go ahead and sign up for the online portion of the testing? Really? You guys are
Hey.
just after a nice break, aren't you?
Hey, Kathy, I was going to actually ask a question about the RQI.
Okay.
They're promoting this quarterly real-time type of simulation. Have you seen that?
No, I haven't.
No? Okay. Okay. We probably won't do it at UNM, but I was kind of curious if that was something we would adopt eventually.
So so it's kind of like you sign in and everybody does the scenario?
Yeah, like you basically have a baby that tells you how you're doing with your resuscitation.
Right.
And everybody practices that quarterly to keep up with NRP basically.
There is that's actually a really good point. There RQI does have a system set up to, if you buy their equipment, people can go in, and if they can go in and quarterly do a scenario, and it keeps them current. And therefore, I don't think that they have to, they're continuously renewed if they do that. And I think for some places that is a really, really good, it's a really good thing to do. It makes people practice their skills. And it also relieves the burden on the education departments to go ahead and have to hold these big classes all the time. So that's something that you definitely can talk to them about. RQI in general has been very, very supportive of everybody who's been calling, and trust me, we've been calling them a lot. So if you want to look into that, and I think there's certain places that already have some of that stuff already set up. They do it for CPR, those type of things. So that works really, really well. I have a question. It says on initial steps, only warming was taken out. Was it? I don't think it was taken out. I think it was rearranged, right?
Exactly. It was just rearranged. Let me see. Let me just go back. Initial step. All right. So we warm, dry, stimulate, position the airway, and suction if needed. So everything's still there. It's just more in the order that we actually do it. It used to be warm and maintain a normal temperature, position the airway, clear secretions if needed, and dry and stimulate. So it just was kind of choppy before.
Right.
And it seems like it's actually ordered in the way that we actually do it now.
Does anybody else have any other questions? All right, well, it looks like you guys are getting another short break. And green starts at 11:05, so make sure that you're back by then. All right, thanks.